Good afternoon, everyone. We would like to welcome you all to the Lilly Symposium. This is going to be presented by Dr. Melinda. Dr. Melinda is actually going to be presenting to us from burn to bliss. As we all know, Dr. Melinda, she's an expert in dermatology with extensive experience in clinical research and practice. Dr. Melinda, she actually contributes to dermatology publications, and she's one of the primary investigators in the lebrikizumab clinical trials. And before Dr. Melinda starts, we're going to be seeing a short video, a 1-minute short video, and then Dr. Melinda could start.
Thank you. Thank you for the kind introduction. And nice to see some familiar faces. I'm so happy to be here in Dubai, especially because it's minus 15 degrees in Canada right now. I believe there's a video that's going to start. To press it one more time.
Welcome and thank you for dedicating your time to attend this meeting. At Lilly, we are committed to following the letter and the spirit of laws, regulations, policies, and procedures that govern the pharmaceutical industry. We would like to remind you that today's discussion will be dedicated only to information that is consistent with the product label approved in our country. Any questions related to unapproved drugs or indications, dosing regimens, populations, or other information not consistent with the PI will not be answered in this meeting, but forwarded to our medical department. Thank you for your understanding, and we wish you a good meeting.
Great. Sponsored by Lilly. Okay, here are my disclosures, mostly based on the research that I do for new therapies in dermatology. So the learning objectives for today's session is to just highlight the heterogeneity of atopic dermatitis, think about some of the unmet needs, talk about that key cytokine, interleukin-13, and the mechanism of action of our newest approved therapy, Ebglyss, an interleukin-13 inhibitor. And I wanted to do that to summarize key efficacy and safety by highlighting cases from my clinic, some patients who were in the clinical trials and some who are on commercial product. So just to start, we know that over 200 million people around the world are affected by atopic dermatitis. More locally, in the UAE, we have a prevalence of 12% of adults affected by atopic dermatitis and almost 17% of children. So this is something that's very common. We're all going to see it in our practices quite regularly. We know that atopic dermatitis is driven by interleukin-13, and we know that because interleukin-13 is found in the cytokine, found in the skin of patients with atopic dermatitis, not only in lesional skin, but also non-lesional skin. It's also throughout the lifespan from infants to adults. It's in all heterogeneous skin types, in erythematous flares, in chronic skin lesions we find it, and it also correlates with disease severity and chronicity. And not only is interleukin-13 responsible for driving inflammation, but it also affects pruritus. So it sensitizes the nerves to pruritogens, which is the main symptom that our patients suffer from. So thankfully, this has been discovered within all of our career time to have a target like this. And so we've had a number of new therapies that have really changed the lives of our patients, starting with dupilumab, a monoclonal antibody targeting the interleukin-4 receptor alpha subunit. Then we had tralokinumab. This is a monoclonal antibody that targets interleukin-13 at a site that is the same as the receptor site. So it blocks interleukin-13 from binding to either the R-alpha-1 receptor or the R-alpha-2 receptor. In comparison, lebrikizumab is a bit different. It binds to interleukin-13 on a site that's different than the receptor binding site. So it still allows it to bind to the receptor, but it blocks the co-localization of the two receptor subunits so that the signal cannot be sent. But what it does allow is it to bind to the decoy receptor and be removed from the circulation. Also, everybody asks, well, what's the difference if they're both blocking interleukin-13? We know from some other cytokine blockers there can be differences within a class. We look at this in vitro data, you can see the rate of dissociation from interleukin-13 is a bit faster for tralokinumab than it is from Ebglyss, and also Ebglyss has a higher binding affinity of about 140 times higher binding. So it binds stronger and it lasts longer in that attachment. So let's look at some of the top-line data. Starting first, just a whole summary of this very robust phase 3 clinical trial program that you can see was done globally. So we have results from all over the world. The key pivotal trials are Advocate 1 and Advocate 2, which are the monotherapy trials. We have the ADHERE trial, which was in combination with topical corticosteroids. These rolled over into the ADJOIN study, which is the long-term extension trial. So one of the differences I wanted to highlight also with lebrikizumab from our other current biologics is we have a double loading period. So 500 milligrams at week 0 and then again at week 2. We have that every 2 weeks for 16 weeks, and then the injection goes to once monthly. So I wanted to just highlight, so it was nice to see the AI generated speaker at the beginning of the video, because all of my cases are also AI generated photos to protect patient privacy. But I just wanted to share some of the cases from my clinic, and I'll try to do it quickly so I don't go over time. So this is one gentleman, kind of looks like the brother of the speaker at the beginning. He presented in his mid-50s. Here's his past medical history on appropriate medications for his coronary artery disease. And he presented with pretty severe disease, particularly on his hands. And you can see from the picture, he actually works as a handyman, working for various contractors, working on building houses. So this was very disruptive to his daily life. He'd used a number of topical steroids over the years, which were not effective, according to him. He was taking antihistamines, but he'd never been on systemic therapy. He presented to me in November of 2020, which happened to be when we were enrolling for the Advocate 1 trial. So I offered him enrollment in the trial. He accepted and was a study participant. So just to quickly look at the rapid onset of action of Ebglyss with the IGA 0/1 up to week 16, 43% of patients in Advocate 1 achieving that target. EASI-75, which in the US was a secondary endpoint, but in Europe was a co-primary endpoint. We had 59% of patients achieving EASI-75 by week 16, but you could see significance as early as week 2 after that first loading dose. Looking at deeper levels of response with EASI-90, 38% of patients achieving this by week 16, and statistical significance as early as week 4 after the second loading dose. Of course, what's important for our patients is the pruritus, 4-point improvement or greater in 46% of patients by week 16, but this was also significantly improved as early as week 2, and you can see that real jump up at week 4 after that second loading dose. So what happened with my patient? For a while, he had a bit of a persistent patch on his ankle, but essentially he cleared, and for the last year of the study, he was completely 100% clear. He had no itch, his DLQI was not impacted, his hands were clear, he was able to work, he was very, very happy. So looking at the deeper levels of response, which is what I think is something important with the development of drugs in this area, IGA of clear skin in about 40% of patients here maintained throughout the year, whether it was Q2 or Q4 week dosing. EASI 100, so 100% improvement, again in between a quarter to a third of patients. And no pruritus, no or minimal pruritus also in 4 out of 10 patients. So what happened? He completed the 3 years of the trial. This was all through COVID. Even though he was an anti-vaxxer, he was quite happy for me to inject him with this experimental drug. He completed Advocate 1 in December of 2023. We did not yet have the drug approved in Canada yet, so he went off of therapy for a full year without flaring. And so he was able to maintain an EASI-90 throughout the last 13 months, and he just restarted his Ebglyss last week, was his first injection. I just received the fax. So if you look at the long-term response. You see this easy 90, steady over time in the patients who were on therapy, but even those patients who withdrew from therapy were able to maintain their response, and I feel that's where my patient sort of landed in that gray line in the last year. So the next patient that I wanted to share with you is an adolescent patient who was 16 years old when she presented, again with severe disease, really significantly impacted psychosocially. In fact, I saw her when she was a very young girl, when her parents were still married. She went off to the Children's Hospital for care, and during that time, she had a lot of issues. Her parents divorced. She was bouncing back and forth between homes, really struggled, and she'd already dropped out of high school when I saw her at the age of 16. So she presented in October of 2020 at my other site where we were doing the INT'L study. And she was enrolled in that, and she actually responded quite rapidly to the medication. So just looking at the adolescent cohort here, we can see the EASI-75 in about 2/3 of the adolescent patients by week 16, and 40% EASI-90 by week 16 in the adolescents. So we're seeing the same responses in the adolescent group as we do in the adults. And on the right-hand side, we have the results of the INT'L trial, which is the one she was in, showing the addition of topical corticosteroids, elevating both the on-drug and on-placebo response rates with the topical therapy. So what happened to her? Well, through the trial, we're assessing them at every visit for AEs, and she did present at week 8 with some conjunctivitis. You can actually see her skin was starting to clear, still a bit pink, but her eyes were red and very watery. So I have a good relationship with my ophthalmologist. I got her in quickly. He started her on loteprednol etobimate drops, and we were able to get those in control. There's her 2 weeks later. She showed up with her mascara on, which is, I think, a good indication she was feeling a lot better, that she wanted to get ready for the office. So as with this whole class of medications, conjunctivitis will happen in some patients. In the study here for the Q2 week dosing, we see a 10% of all conjunctivitis in the drug group compared to 3% in the placebo. Injection site reactions also very low, 3 versus 2, and herpes zoster also very low rates. So nothing new that we're seeing in this class of medications. So looking at the conjunctivitis over the first 16 weeks, we see that early on they do present. Whether the rates drop because it's less likely to happen, those who are predisposed will declare themselves early. We get them on proper treatment, but rates do decline over time. So I like to warn patients to start using lubricating eye drops early on when I start them on an IL-13 inhibitor. So the last patient in the last couple minutes here, 37-year-old female who has a lot of mental health issues with her severe atopic dermatitis. In addition to anxiety and depression, she has agoraphobia, so she does not like to leave her house, except when she's significantly flaring. She'd been to the emergency department on 3 occasions in a row and put on prednisone, and finally the 3rd time the emerge physician referred her to me looking for another option. She is in a very strained relationship with her abusive husband, according to her. So she has a lot of issues, but her husband's the one with the drug insurance, so she feels a bit trapped. Here she is presenting very acutely. You can hopefully you can see how red she is. At the top there are chronic lesions on her legs. And she was so desperate, she just wanted me to give her more prednisone, which I was not going to do. So I put her on Rinvoq 30 milligrams. That was back in February 2022. She did very well. She felt really good for a while, but then she failed to do any of the blood work I ordered. She failed to get any vaccinations because she would not leave her house. She failed to return for her follow-up appointment, ran out of medication, had a severe flare, rebound. She'd apparently moved out of the house from her husband, staying with her sister, and she didn't want to go back on Rinvoq. So at that point, I started her on Dupixent, and she did start to improve, but she had a lot of anxiety with the needles. She was missing doses. She would go off therapy, and she just kept showing up flared. So we decided, after a long discussion, that Ebglyss, she could take fewer injections, I felt there was some good stability of response based on my previous experiences, and she's been on Ebglyss now with some very stable control. So I'm hoping that she stays on the medication for her own mental health. She doesn't like to use steroids, so just to highlight that 86% of patients were not using TCSs and TCIs across the 36 maintenance period and were able to maintain their response. So this is an option for patients who don't want to use their topical steroids. So in the last few seconds, comes as a 250 milligram easy to use pen. As I mentioned, you get 2 doses at week 2, again at week 0 and 2, and then every 2 weeks for 16 weeks. And then after that loading period, it's 13 injections a year, which is the fewest injections of all the biologics we currently have available for those patients who are concerned about injecting. We can use Ebglyss with or without steroids. We have good data for both. There's no lab testing, no monitoring for patients who don't go for blood work. There's no dose adjustment. Everyone gets the same dose, but we do recommend vaccinations. So finally, it starts strong with the 2 loading dose. It lasts long. I have patients stay stable for a year off therapy. You can maintain your effect with a monthly dose. And of course, it's been studied globally with a very robust program. So thank you very much for your attention. I think I only went over a couple seconds.
Thank you very much, Dr. Melinda. Thank you very much for this informative talk. Any questions? Until the questions come up, I can ask you a few questions, Doctor. So since we have different types of biologics now in atopic dermatitis, what is your say with regards, because we keep on discussing dual blockade versus the single blockade, that's one. And what is the best patient profile to use Ebglyss? Who would you choose the treatment for?
I would find, like, so for example, an adolescent patient, when you bring up the word injection and you see their eyes widen or them recoil from you because they don't want to have an injection, it's nice to say there's an option that has a monthly injection. I find that some patients have made the decision based on that. Having had the experience with my patient who did very well, who was in the trial, and then was off for an entire year without a major flare, really gave me comfort in the stability of the response. So if a patient has to miss a dose or for whatever reason, surgery or travel, or a patient wants to take a drug holiday, I would feel like this is a good molecule for that purpose. And yeah, those are the main reasons that I would want to just discuss that with my patients.
Any questions? Do you believe in future they're going to be using it also for atopic comorbidities? May it have a role as well?
For the comorbidities, yeah, I do believe, like, I think some of the data hasn't shown the IL-13 inhibitors as effective as 4-13 inhibitor for studies like on asthma. I don't know if the studies were done properly. I do have some patients who still find the 13 blockade is helpful for them. It's not, of course, on the label, so we don't talk about that, but I don't see a reason why not to use it in a patient because they have other comorbidities.
So I believe no more questions. Thank you very much,
Okay,
Dr. Melinda.
thank you very much.
Talk.